Good evening and welcome to COVID-19 updates from Singapore. This is episode 35. I'm your host, David Allen, along with my co-host, Louisa's son and Dale Fisher, welcoming you to another episode. And thank you for spending your evening with us. We have a chock-full meeting as usual, a session, and we're looking forward to sharing with you. Louisa, what are you going to be chatting with us tonight?
Oh, the post is all about me this month. So what I'm going to be sharing is, what is closely related to the questions that we have on there.
Okay, good. And Dale, you found a friend?
I did. The more you realize as you're wrapped up in this outbreak world, the more people that you know, and it's always great to connect with people. I found Thierno, an African colleague that I did some trainings with a few years ago. So we'll catch up with him later.
Super, great. Well, let's jump right in. The session this evening will have focused epidemiology for a segment from Dale, followed by and his conversation with Thierno, and then Louisa will have a discussion on a topic of interest, and then I'll do the vaccine round. There'll be we'll close with the pandemic song of the month and a video from Dale's archives. We may not mention you by name, but we'll try to answer all your questions throughout the session, and we appreciate you continuing to send those in. Just a reminder to submit your questions through the chat box and through the emails that you receive in between these episodes. Without further ado, over to you, Dale.
Great, straight into it then. So here's the global situation, as always, with the slides I'm lucky to get from WHO through the 6 regional offices. You can see what's interesting now is you can see these 3 sort of waves. Don't like the word waves, but anyway, you can see these 3 peaks in cases. But and in the past, the deaths, which is the black line, has tended to parallel these. But that's not happening so much now. And I think this is what we're seeing with vaccination, that we're still seeing lots of cases, but we're getting a plateauing off of this death rate. Still not acceptable, obviously, but and you look at the UK here, ranked number 3 in terms of cases, but look at their number of deaths in that 24-hour period. So again, no deaths are good, or no deaths are acceptable, but in terms of an epidemiologic look, it's what we're seeing with the well-vaccinated countries. As we look through the 6 regions, you might remember that last month, I just wondered if we were starting to get an uncoupling in the Eastern Mediterranean region. And as you can see, we weren't. We've only seen this uncoupling of deaths and cases in the Americas and also in Europe. What we're seeing in the other places is very high numbers being paralleled by the deaths. Southeast Asia, we're seeing good outcomes, I guess, from the lockdowns in Indonesia and India, but and also Thailand have all driven those numbers down. Okay, so let's look at the states, which is now ranked number 1 again in terms of cases. You can see the number of deaths, the number of deaths over here are on the climb, the number of cases are on the climb, and we're going to see a very heterogeneous look in the United States, especially as we get into winter with Alabama, Mississippi, Wyoming, lots of those states down the south and southeast. Their vaccination rates are sitting in the high 30s, so really inadequate. Up in the northeast, we've got Vermont, Massachusetts in the high 60s. New York actually is only just on 60, so you'd argue that that those rates are not good enough as well. This can anyone else hear the dog? This is called work from home.
Yes. Why don't you feed the dog, Dale?
Do you want me to go and have a quiet conversation with my neighbor? No. Anyway, so this 60% that we see in like we've seen it in Europe, we see it in UK, and this is very much a ceiling that we're getting in a lot of a lot of countries, and we know that the first people to get vaccinated are the early uptakers, if you like, and it gets harder the higher that number is. So we'll come to more of that in a minute. But so we see this uncoupling here in the European region, but it's not absolute. You can still see that there's a creep upwards. And just down here as an explanation, I won't go through this paper, but it's a nice preprint that has looked at all a lot of recent mass gathering events, and they have in fact been super spreader events. The England-Italy soccer match, there were, I think, about 60,000 people went to that, and there were 2,300 people that went to it that were infected, and afterwards there were 3,400 more that became infected. And there's similar sort of numbers, although not so high, but lots of transmission with the British Grand Prix and also Wimbledon. So nice paper if you like reading that type of thing. Now, as we look here, again, in terms of the outliers in deaths, I've said this the last couple of times round, Russia, Kazakhstan and Georgia, their low vaccination rates are leaving them with high death rates per million population. The UK death rate has actually, it's still quite low, and that's actually doubled in the last month. But again, mostly these are in the unvaccinated 30 or 40%. And obviously with very high case numbers. Germany is here, so their numbers are down. They've actually announced that they're not going to be having the same focus. Singapore announced this some months ago, having the focus on case numbers. So I just wonder if they're trying less hard to find the cases, although their death rates are also very low. So that validates the case number. But the point with this is, if you're not trying to contain it, if you're not trying to keep the case numbers down, then it's not a very good thing to measure. And I'll come back to that with the Singapore report towards the end. So this is also likewise, we're seeing this trend of increasing cases. All the reds and browns mean that they're increasing with the legend over here. And again, and I just wonder, for where it is, Belgium, Scandinavia, very small case numbers. I just wonder if they're making that transition. I'm just speculating, but are they making that transition towards less mass testing, for instance? This is the Southeast Asian region. As you can see, the graph is really dominated here by the cases from India and Indonesia. And you can see their numbers have fallen quite sharply. Thailand up. So that's why this graph is taking this shape. Deaths are still quite significant as part of the lag from all those case numbers, and presumably there'll still be overwhelmed healthcare facilities. So yeah, as we look here, we can see that these case numbers are descending really across the board, although still very high in Thailand. Indonesia and India particularly, it was the lockdowns, and also Thailand. It's really the go-to activity now when you sort of max out your public health issues and your borders aren't helping. Bangladesh has got a test positivity rate of about 30%. So that's sort of telling here. We've always been aware that testing can be a problem here. They've started vaccinating the Rohingya refugees. You remember in 2017, there were about 1 million refugees came across from Myanmar and settled on the border there. This has been effectively a permanent camp for the last 4 years. These people won't go and get tested because they're worried about what can happen to them. Even some fear that they'll be put to death if they've got a positive test to try and control the outbreak. So I don't believe that would happen, but nonetheless, it's very hard to get numbers in these areas. But through IFRC, the Red Cross particularly, they've started doing vaccination there. So some good news in a difficult circumstance. As we go to the Middle East, again, you've got a very typical paralleling. You've got these waves of increasing numbers of cases, essentially related to whether you're locking down or not, and the deaths are very much paralleling that as we go, and that's because the vaccine's still fairly inadequate here. There's records. If you look at the height of these little epicurves here, Iran, Morocco, Iraq, Pakistan, Libya, these are all setting records, but Iran is having sort of massive numbers of cases. And you remember it was the one of the very early epicenters, same as North Italy in February, March 2020. So they're struggling again here. The highest death rates, Tunisia and Iran, and I'll just come to that here, because you can look at the very low death rates, which are UAE and Saudi Arabia, and the reason UAE and Qatar, and the reason I'm showing that is because UAE and Qatar have got these incredibly high vaccination rates, and these are a couple of days ago, so they're even higher than this now. So UAE and Qatar are high, whereas Iran and Tunisia are down here. So you're getting a very heterogeneous outcome in vaccination in this part of the world, and it's really, I think, a nice illustration of how vaccines really save lives. The poorer vaccinated places have got very low death rates. I'll just toggle back to the last one. Very low death rates, whereas the poorly vaccinated countries are the ones that are really doing it tough with their high death rates. So in Africa, similarly, we've got synchronized these waves of high case numbers, and with it the deaths are aligning with it, and this is pretty much aligning with poor vaccination rates as well. So South Africa has always been the lion's share of the continent, but really surely due to its ascertainment, and many of these countries are coming off their recent high levels. So that's why there's some improvement across Africa. You can see there's quite a lot of blue, which means overall improvement in case numbers and deaths. And again, my friend and colleague will elaborate on this a little bit later. I wouldn't get too fussed about comparing the rates with other parts of the world because we know there's different ascertainment capacities. But let's look at these. This is a whole lot of African countries I threw together on this Our World in Data interactive graph. So here's Africa at like 4.6 for one jab and about 3% for both jabs. But it's a remarkable difference with Seychelles, Mauritius, and Cape Verde. And I just wondered why these were so different, apart from what you might postulate is these are beautiful places, and for some reason Seychelles attracted Sinopharm, which was donated by UAE, AstraZeneca from India, and then got some Sputnik, so that got Seychelles, obviously a fairly small country, into these high rates. And then Mauritius is now open. They got a lot of AstraZeneca donated by India. And Cape Verde has also got some quite nice tourist spots. They're mostly COVAX, I think, through AstraZeneca, with using AstraZeneca and Pfizer, and I think some Chinese vaccines. So anyway, just an interesting observation over poor vaccination rates across the whole continent, with three small countries, which are tourist destinations, doing very well. I guess it could be rationalized in terms of economy and things as well. So let's go to where we are, Western Pacific region. You can see this speaks for itself, just skyrocketing numbers of cases, and with it in parallel numbers of deaths, and really every country is, or most countries are breaking records. So Japan's at its highest, Malaysia's at its highest, Philippines, Vietnam, even South Korea, French, all these countries breaking records. Even Australia is having a big influx, and Cambodia has been there. Fiji's just coming off a peak. So French Polynesia is that's got a population of 280,000 over 100 islands, and in the last week 8,000 of them got COVID. So Brunei is having its first peak. So with 1,000 people, and their population's only 433,000. So what we're seeing here, and there's this very interesting. You can see all these countries doing so well during the pandemic until now. Some of the countries have had little clusters, but they've been put out and got back to zero, but heavily reliant on border controls. And once they're breached and the virus is in, then it's very hard to put the cat back in the bag. And they're really faced with when they're poorly vaccinated, they're faced with the non-pharmaceutical interventions and lockdowns up to various levels. So let's just talk a little bit about Vietnam, which is about 2% fully vaccinated. 16% have had one jab. They had quite a few little clusters along this, but they did what China and Australia and other places have done, which is do lockdowns, mass testing, and get back to zero. But obviously, over the last couple of months, it's gotten away from Vietnam in both its cases at over 10,000 a day now, and deaths are up at sort of 300 or 400 a day. So it's quite sad. They're in lockdown. They've brought the military in. Ho Chi Minh is the epicenter. This is a picture actually of Hanoi, but nonetheless the same effect. So the military are enforcing stay-at-home orders until September 15th. So they're really trying to get this down, and while you sort of buy some time for the vaccine. The Prime Minister has said people must stay put. They must isolate from each other, from house to house, and from community to community. So let's hope things go well in Vietnam. But as I mentioned, there's really a lot of these zero small countries, island nations. There's even recently been a new cluster in New Zealand. But all these places will eventually need to confront COVID, assuming they don't want to keep their borders closed forever. And there's a few more there. And as I look at their vaccination rates, actually quite promising, quite reasonable. But they're going to have to face one day that while other countries ease restrictions with vaccine rates going up, these countries will have to introduce restrictions when they get to 70 or 80% and open their borders, or else they're going to find a surge in those unvaccinated people. So it'll be interesting times for the zero tolerance countries. In Singapore, some people might be distressed by the recent couple of clusters. I actually think it's good. We do need to feel more comfortable with local transmission, because as we ease restrictions, that's what's going to happen. So to remind you, the green ones are okay. The blue ones are linked, but they're not in quarantine at the time of diagnosis. And the yellow ones at least start off completely unlinked. So the yellow and the blue are what you're going to find when you've got a very mild disease, which it essentially is for the vaccinated people. So you get this silent spread. So these case numbers, we're still tracking them, we're still declaring them every day, but they will become less important. What's going to become more important is this, which is the deaths and the active cases in ICU or requiring oxygen, and looking at it by vaccination status. So you can look here at the deaths, and all these ones are pink, so they're the completely unvaccinated. So apart from one fully vaccinated person here and a partially vaccinated person here, all the rest were unvaccinated. And remember, most people are vaccinated, so these people are clearly overrepresented. Likewise, in the intensive care unit, vast majority of pink, very small number of blue and grey. And remember, these are the majority of people. So again, the pinks are grossly overestimated or overrepresented, and likewise requiring oxygen. So we need to be watching this to see if the numbers change, and if we start to see big, we will see the numbers change, because many of the vaccinated people, of the unvaccinated people, will become vaccinated. And indeed, eventually everyone on this chart will be, if 100% of people are vaccinated, then 100% of people will get that get the disease will be vaccinated. That's common sense. So we will see vaccinated people getting disease, but we don't want to see it creeping up. Cases in the last 14 days by age group. And again, this is something we have to get used to. All these black ones, whatever age you are, these are the fully vaccinated people. So we start to see, because so many people are vaccinated, we start to see more vaccinated people get disease. It's a simple understanding, and I know we're going to hear more of this from Louisa and David. This helps you be reminded that if you are unvaccinated, you've got a much higher propensity to needing oxygen, to needing ICU, or dying. It's a bit less in the partially vaccinated, and it's really quite low in the fully vaccinated. But it's not zero. We're not pretending it's zero. This is also what's important, and this is the number of people that are placed in quarantine after coming back from travel. So the greens are detected upon arrival, and the yellows are detected during their isolation. So if you go back, like, for the last 2 weeks, there's, I think I added up 13 people that had COVID. Now, when you're having 100 COVID cases a day, and the amount of effort going in to catch these 13 people is obviously out of proportion. So I think this is why you'll hear more. We've already heard some from government that we need to loosen up these borders. This is not bang for your buck. This is stopping a very small number of people, but at great expense and great inconvenience. So this is a good argument for quarantine to be eased. It doesn't have to be black and white. It doesn't have to be wiped out, but it can certainly be made easier by perhaps quarantining at home, or having more tests, or selecting countries or something like that. Okay, so this is where we are now. This is people that are fully vaccinated. Okay, so this is more than 80% in every age group of the eligible. I showed you this one last week, which was last month, 19th of July data. So this is why we had to wait a month, right? Because there were so many people that had one jab but weren't yet fully vaccinated. We knew if we waited 2 or 3 more weeks, they would all turn into 2 jabs, and here you are. So likewise with that, here's the 1 jab rate now. So we can tell that more than 90% of the eligible people in the next 3 or 4 weeks will be fully vaccinated. My last comment is just to remind people, when we hear about all these other countries that are well vaccinated, Singapore is actually higher than all of them. It's been an incredible effort. This is our world in data. Actually, the truth now is this number is not 74, it's 78, and this is 82 based on the local data. So, but you can see we're comfortably 10 or more % ahead of all these other countries, and really we've got no model, no one else to say they did it this way. We can only say that opening up with opening day or freedom day is probably not a good idea. Okay, well, that's all I had for the epi today. I now just want to flick over to a recent meeting I had with Thierno Balde, who is a colleague of mine. He's from the Ivory Coast originally. He's medically trained. He's a doctor. He's got a master's. He's got a PhD in Montreal. But most importantly, he's the COVID-19 deputy incident manager based at the WHO African office in Brazzaville. So I started by asking him, what's your role in the outbreak, Thierno?
Thank you, and good morning, Dale, from Brazzaville here, where we have the regional office of WHO. Yes, I've been the deputy incident manager for the regional office of WHO, supporting the COVID-19 pandemic response in the 47 African countries which are covered by our regional office. And it's really good to see you since we met in 2018 here in Brazzaville when you came with the one partners, some of our colleagues, for really supporting our country offices and also our partners in preparing to this type of situation that we are facing now. So it's really nice seeing you again. Thanks for the opportunity.
Yeah, Thierno, that training seems like a lifetime ago. But you brought up the partners. Tell us how the different partners that probably in Africa most of the time already, IFRC, UNICEF, and so many others. What's been their role through the pandemic in Africa?
Yeah, given the complexity of the pandemic here, we really need the involvement of all of the different partners with their level of expertise. We have learned a lot. So we have partners, as you rightly said, like IFRC, which has been playing a major role, in the engagement of the different communities, which is quite very important given the limited, options that we have for responding to this pandemic. So engaging the communities in a very regular manner, in a very effective manner, has been something which has been very useful. And we have also new partners that we've been engaging, and which are linked to the existing partners, ground level partners, which are helping us again, to mobilize members of the different communities and for really adopting these public health measures. And all of the work also that we did, for reinforcing the epidemiological surveillance, through the go-on training that we did last time. I remember there was almost 10 or 13, representative of partners, active here in the region, being either the CDCs of Nigeria or also AFENET from Uganda. We brought them together, for really trying to have this real-time somehow simulation, of this training for anticipating this type of situations. So we tried, for responding to this current pandemic, we try really to build them to leverage on all of these different capacities. And obviously we are still looking forward for increasing those capacities, for addressing the current challenges.
And of course, the largest partner of all is your organisation, the WHO and the African region. So tell us some of the things that the African regional office has been involved with.
Yeah. First of all, as per the mandate of the WHO, the provision of really effective, and timely technical support is really one of the high priorities. So the deployment of expertise, through the mobilization of from the partners or also from other, resources and stakeholders for going to countries really, because the actions are happening at the country level. So the discussion that we are having in the countries to identify really the real needs, the most, urgent needs, and then to deploy some of the technical expert, be they, expert of IPC, on case management, on community engagement, on coordination. So we have really deployed hundreds and hundreds of people, almost 500 experts since the beginning of this pandemic, for supporting directly to different countries. So obviously everyone was stretched, but the identification of this additional expert and the orientation, the guidance, for the deployment, this is something which has happened, over the past 1 year and a half. Secondly, I will also mention about all of these materials and equipment, including the PPEs, for helping for the prevention of these controls happening, both at the community level or also at the hospital level, at the facility level. So tons of materials have been really procured and shipped for helping, the protection of the healthcare workers, because we know this is really a major challenge. If people who are treating the patients, the COVID patient, if they are sick, therefore that will be a problem. So really reinforcing that component on the IPC has been also a major point that we have done. And also we even organized the deployment of some of the emergency medical teams also, which came, from abroad and from the region here to go and to help for the treatment of the people. Because at the end of the day, we wanted to save life also. So individual experts, group of experts going, for the case management of severe and also critically ill patients. And obviously, last point, it's also about the vaccination. That was a major challenge. It's still a major challenge challenge. Like in June, we almost we know that with the COVAX system, which were really, I mean, not that much working. I mean, given the limited number of vaccines available for the region here, but we are seeing more and more now a commitment becoming a reality, you know, for really getting this vaccine on the ground.
Yeah, I'll come back to vaccines, but firstly, let's just talk about surveillance. The rest of the world's obsessed by numbers. It looks like Africa's surging at the moment in terms of numbers, but is that just better ascertainment now, or do you think there is a more serious problem?
Look, to my point of view, we'll say that, you know, we are really following and monitoring very closely these countries with the surveillance system that we've been trying to implement. I mean, in all of these different countries, I mean, there's been some improvement, but we still know that there are some challenges and limitations into the effectiveness of the surveillance system. However, what we can say, I mean, looking outside and saying, like, at the end of the day, when someone got sick, I mean, and severely sick, usually if there's no really major referral issue, the person goes to the hospital. So having really a closer look at the hospitals, I mean, how far hospitals are full, how far hospitals are really overwhelmed. This has been a major indicator which are telling us, I mean, how the pandemic is evolving. And we have seen that in some of the countries, given the past few weeks. You know, this is where currently at the third wave of this pandemic, and this has started almost 9 weeks ago now, and we saw really a major increase in number of cases, mainly driven by South Africa, but also countries around South Africa. And in those countries, definitely the hospitals, they were full. However, now what we have started to see, I mean, during the past 2 to 3 weeks, it's a declining trend of this pandemic, mainly driven again by the declining trend in South Africa, where we know hospitals were full, but I mean, we are starting seeing a kind of less tension in those hospitals. So it's the same perspective in the other countries. When we come to Central Africa, West Africa, and others, I mean, we are not seeing hospitals which are full. I mean, hospitals which are totally overwhelmed, and again, so this is a kind of indicator. And if I can go at another extreme, when you go to the cemeteries, we are not seeing, I mean, massive burials, I mean, activities, I mean, happening at night as we have seen in other countries or in other regions. So I do think this can give us a perspective, I mean, just to balance and to have another I think, dimension or another vision of what is really happening in Africa. And just to finish, you know, deaths, let's say, everywhere in the world have a kind of social, emotional, you know, cultural component. And so wherever, if there were really massive deaths, I mean, it will have been, we will have been able really to notice it and really to know more about it. But I can say definitely the situation is very challenging. We see, especially with the Delta variants, with the high transmissibility, you know, with the infection of younger people and things like that. The situation is concerning, that's for sure. But I do think that we are seeing somehow a certain level of reality through the information that we've been sharing and through the monitoring system that we have established for the surveillance of this pandemic.
So you mentioned things are getting better. What worked? Are you good with masks and social distancing, or are you doing lockdowns like some countries?
Yeah, I think it's a combination of both. It's really a combination of both. First of all, definitely, I think whenever we ring the bell somehow at the WHO regional office here on a weekly basis, you know, our regional director, she's having these press conferences where people are informed about, I mean, the trend, the evolution. We are talking at different forums saying, something is happening here. Something might happen here in 1 or 2 weeks, you know, in this country. We really put the focus during the past 6 weeks, you know, on Southern African countries and really with major interaction. So with those type of, I mean, advocacy and information, therefore countries are taking measures also. So the strict lockdown, and we saw it in South Africa, we are seeing it in Zimbabwe today, in Zambia. So definitely it has helped a lot. in DRC. It has helped a lot. Now the other component on the treatment of the people also, as I was saying, for the critically ill patients. So trying also to limit the deaths of those people. This is also something, which is really critically important. And last point, maybe last 2 points, is the community engagement component, as I was saying. So supporting that a little bit more. And in Africa here, somehow in many of these areas, we are used to this type of outbreaks. Africa, we have almost 80% of our public health emergencies which are outbreaks. We are used to that: cholera, Ebola, all of Lassa fever. So at least, authorities or national health authorities that we've been supporting are used to manage those type of situations. But I have to admit that we need to do more, but at least there was those habits, for handling this type of situation. And the last point, it's probably one potential explanation. I think it's the limited connectivity that we have also in the region here, from big cities to smaller cities. So the movement of the people is a little bit less important, and obviously the structure, the demographic structure of the region here.
And I know those other outbreaks haven't taken a rest because of COVID. They're still happening. Listen, let's go to the vaccine then. Firstly, is Africa angry? Just the way it's been, in a way, disrespected by other countries, just grabbing the lion's share of the early vaccine?
I think let's stay politically correct. Let's say that Africa is hungry as African by origin. Also, for sure, it's a quite disturbing situation. But again, efforts has been done. I think with all of this noise, let's say, or angriness that has been highlighted by different people, mentioning that this is really unacceptable. There've been some moves, for trying to make more to bring more equity into the distribution of these vaccines. And as I was saying, in last June, we were really in a situation where the COVAX system was almost halted, virtually halted, and no really vaccine coming. But with all of the advocacy and all of the information that has been shared with the different stakeholders, I think things have started moving, and we are seeing more and more engagement and reality in the engagement of the different countries, or wealthier countries, let's say, but also these private companies, for the provision of vaccine, through the COVAX system. At the meantime, also, we have also to say that, all of the countries have struggled through this pandemic, being in the United States, in Europe. We have to admit that, so definitely we are just probably not lagging behind, but the situation started there in Europe, in Americas, it's coming to Africa, and obviously there's no local production of these different vaccines. So, but countries also, there is a mechanism which has been put in place by the African Union, the AVAT, for the procurement. So in addition to the donation, countries now also are really making major efforts, for buying their own vaccines, and also for then addressing the needs of the population. But definitely, I think having more vaccines, having more of these oxygen procurement, this is something which can really help us. And if you have to make a plea or a kind of request, I think, to the international community, it's about how can we get that, quite quickly, not to go through the normal market somehow, normal global market, which is under tension. Definitely for the production of and distribution of oxygen. But if you can get those type of things through bilateral arrangement, I think that can help a lot, African countries. And obviously we continue working together through different platform and partnership initiatives, for learning from each other, but also for reinforcing what we've been doing over the past months.
Yeah, that's very politically correct. I think the DG is angry though.
Yes, so then I will say yes.
Listen, this is one of the great things about Zoom, is you can connect with old friends, and it'd be I look forward to when I can see you again in person, Thierno.
Thank you, Dale. My pleasure.
Thanks, Dale. That was a very, very helpful perspective from an important part of the world that I'm sure we'll hear more about. Thank you for reconnecting with him. Louisa, over to you.
All right, so this gives away the topic for this evening for me. Good evening. So herd immunity is actually one of the popular questions that we've always been receiving from our audience. And so I thought, what better time to address it than now? And as we're currently transitioning into an endemic state of COVID locally in Singapore, some other countries have already done so, some are trying to do so, some are still trying to hold out for a zero COVID state, but among those, some have also realized that increasingly that's not seeming possible anymore. So contrary to what the debate on herd immunity may be, there's actually quite a clear answer to what or how we can achieve it, or whether we can achieve it now. And hopefully we can come to understand that answer through the course of this segment. So just a quick introduction to what herd immunity means. I'm sure many of you are already familiar, but some may be a bit confused as to how herd immunity relates to vaccination rates, or whether it does at all. So simply put, herd immunity is achieving a state of protection at a population level against a particular infectious disease by building immunity in a large enough proportion of that population, either through acquired natural infection or through getting vaccinated. So when there's a large enough proportion of the population that has immunity, they effectively form a shield around those vulnerable individuals who don't have immunity by stopping the transmission of the infections reaching them in the first place. So this basic concept is of course no different for COVID. Getting to herd immunity means that we need to have a significantly large proportion of the population infected or vaccinated. And not only this, the vaccination efficacy for disease transmission must be very high. So just keep that in mind as I go along. So everyone has probably a vague idea as to how herd immunity came to be applied to us, humans as well. It did indeed originate from livestock. And if we take a look at a history behind it, we find that indeed it was first originated in the 1910s when there was an epidemic of spontaneous abortions amongst cattle. And that became the leading threat to their survival and numbers. Subsequently, in 1919, a bacteriologist performed a series of experiments in mice and concluded that if there was an increased prevalence of individuals in a community with immunity to a disease, that could put a stop to an epidemic. And over the next few years, the term herd immunity was increasingly applied to humans through studying diseases that tend to produce high immunity rates. And in the 1930s, the concept was started to become much more widespread to other countries as well. It was also then that social, geographical, and economical factors were also recognized as important contributors to achieving herd immunity, as subpopulations were realized to have very different living conditions. So over the 1950s to 1960s next, new vaccines were developed, including to polio and measles, mumps, and rubella. And this further sparked discussions and debate as to what is the perfect or what is the required proportion of population that had to be vaccinated to control or eradicate a disease. And this search has actually continued all the way till today, and it continues even now. And the answer to this really lies in the details. For example, if we're talking about smallpox, that vaccine efficacy was extremely high at preventing disease transmission. And therefore, as we know, herd immunity was achieved and the disease has been eradicated. And in contrast, though, if we look at influenza, for example, which the vaccine efficacy for preventing infections is much lower at 40 to 70%, we can see that there's no possibility of elimination and we end up living with the disease. So in a nutshell, what I think you'll realize is that the current COVID-19 vaccines do not have a high enough efficacy at preventing transmission of infections. And so it's not possible, and also it's not possible to have about 90% of the world's population infected with COVID, or so I hope it's not, at least I hope it's not possible. And we're not realistically, therefore, going to be able to achieve herd immunity with what we have now. So in order to achieve herd immunity for COVID, we actually need to have future vaccine development to produce vaccines that are above 90% effective at preventing transmissions. And hopefully there's work in progress on this ongoing, and hopefully that will be realized soon. So this also brings me to my next point, and it's an important point. Not being able to achieve herd immunity, though, does not mean that vaccinations or vaccines are failing or that they don't work. There are two important functions of any vaccine. One is, as I've been talking about, to prevent disease transmission, but the other equally important function is actually to prevent serious illness and death from infections. And for the latter, the COVID-19 vaccines are still performing much more than adequately. But now you will probably also realize that most reports that we see, even the scientific ones, and not to mention the media articles, wouldn't immediately distinguish between which vaccine efficacy they're talking about. So again, this has probably led to the spread of some misinformation, although probably unintentional in this case through unawareness. But it can be harmful because in the end, it can lead to the wrong impression being sent out. So this is a slide from CDC that can help to further illustrate this. You'll see here that there are a number of reports from different countries that do make an attempt to at least differentiate between symptomatic disease, patients with symptomatic disease, and those who require hospitalizations or have had deaths from COVID-19. And you already see that there is quite a wide difference between the vaccine efficacies that are reported for each of these conditions, or for each of these patient subgroups. However, there is one important factor that is missing from all of these reports, and these are asymptomatic or mild undiagnosed infections. And therefore, none of this actually really represents a complete picture in any of these countries. So whereas we know now that vaccinated individuals can also transmit infections, it's quite difficult to know actually what is the exact level or the exact efficacy of the vaccines in preventing transmission, exactly because the published data usually looks at symptomatic patients and diagnosed infections. And so we don't know what the true numerator is with asymptomatic and mild undiagnosed or even unreported infections. But again, despite this, just to highlight that we should still be reassured, and this is as Prof Dale has mentioned as well, that current COVID-19 vaccines really work well in fulfilling one of the two traditional roles, and they are highly effective in preventing severe illness and death, and that is something that we definitely want. So while vaccine effectiveness in preventing transmissions is a work in progress, and this fundamentally answers why herd immunity is not at the moment possible to achieve, we also know that Delta has actually put a great dent into vaccine effectiveness in preventing infections. And furthermore, on top of that, there are several other factors why individual vaccine effectiveness can further drop. Moreover, vaccine inequality around the world and overall low vaccination rates on a global scale are really major obstacles that have yet to be overcome. And so collectively, we're far from from achieving a high enough overall immunity level on a population scale, either from vaccinations or natural infections, to provide that effective shield, as I mentioned earlier, that can protect the vulnerable individuals in a population from getting infected. So now let's go through some scenarios that can occur with COVID. So this is if we had a highly effective vaccine, as we initially thought, 95% effective at preventing infections and transmissions, and with a 100% uptake rate of any population, you can see here that we will end up with some infections still, but they take up a very, very small percentage of the population. And this is actually what herd immunity will look like. But as I mentioned, even though vaccine efficacy is actually quite hard to estimate accurately, let's take this about 50% from an MMWR report. And we see that if the uptake rates are still maximally achieved at 100%, the math is not difficult. There's going to be about 50% of the population who now get infected. And let's throw in a bit more reality now. We have a vaccine that's about 50% effective at preventing all infections. And if we take, for example, Europe, their vaccination rate is about 45%. And look at what this does to the infection rates, the proportion of infections. It drives it up all the way to 80%. Now, of course, as we've also heard from Prof Dale, there are some countries with higher vaccination rates. At the start of the week, UK stood around 61%, Israel about 63%, and in Singapore, we actually have quite a high vaccination rate of 78%. But even so, we can now appreciate that it's not difficult to imagine why case numbers are still going to be very, very high globally, especially in those countries where vaccination rates are still very, very low in the single-digit percentages. And this is just to show the picture can further be muddled because the numbers that you see in reports are hardly a reflection of what the bigger picture actually is a lot of the time. As you can see here, an incomplete snapshot by each of the yellow and purple boxes gives you actually a very different idea of what's going on in the same population. So again, we should always be careful about only looking at numbers that we're reading without understanding what the full context is and whether the data that we're actually seeing only represents a small snippet in time. So now that I've painted probably quite a bleak picture, but there's still good news. And that is, as I've also mentioned, that even though infection rates may still be high at this stage, vaccines are highly effective in preventing serious illness and death from COVID-19 infections. So this helps really to prevent those who are infected from needing hospitalizations or ICU care and mechanical ventilation. And so there's really still every reason to continue to push for higher vaccination rates, because also remember that when case numbers overload healthcare systems and hospitals, they can break down and collapse. And that really leads to even higher morbidity and mortality. While we have increasing vaccination rates, I also just want to mentally prepare you for the quote unquote negative news that you may continue to see. And this is because even as vaccination rates hit 100%, the fact is that there will still be individuals who may not have an adequate immune response due to various reasons, and they may still get infected. And this will be a very, very small percentage, but they may also have underlying medical conditions that can still predispose them to death and serious illness from COVID-19. And therefore, we may not be able to achieve zero deaths, even with very, very high vaccination rates. But the current vaccines and with further development in vaccines can make COVID a disease that we can safely and comfortably live with. So, and finally, these are just my quick few take-home points for today. It's clear that COVID is here to stay. We have to learn to live with it, at least for a while more from now. So while vaccination is one of the most important tools that we have for transitioning to endemicity, don't forget that other measures like mask wearing as well as social distancing are still very, very much needed, and they're not likely to go away. And at the moment, we have to put the idea of herd immunity on the back burner, but that's also okay because work in vaccine development is far from done. And even though the current vaccines weren't the shining star that we thought they would be in preventing infections per se, they still are doing a fantastic job at preventing serious illness and COVID-19 deaths. And so as our message has been and always is to get as many people vaccinated as possible for the best outcomes. And so that's all from me today.
Thank you, Louise. You've taken a very complex subject and made it consumable. Thank you very much. Well, I'm going to hopefully transmit a lot of important information in 18 minutes or be strangled in the process. Let's just jump right in. These are the vaccines in use, and I turn on my pointer. And the ones in red with the red numerals have not changed. There are no additional countries have taken them up in the last month. The ones in black have increased, and the ones in blue over here are new countries in ASEAN where these drugs, or excuse me, these vaccines are now available. Red just means that these are through the special access route in Singapore. And WHO has only distributed 209 million doses to 138. The goal continues to be 2 billion. So that is looking hard to attain. These are drugs, vaccines are available only in one country. Again, all of these, no new countries took them up, but these are 2 new vaccines available in the last month. This is a novel platform compared to the other vaccines available around the world. This is a DNA-based vaccine as opposed to an RNA-based vaccine. There's no phase 3 data, and it's available only in the country where it was developed. So it'll be interesting, hopefully, that they'll share some information about their experience. This was talked about earlier, and I just want to give you perspective. There's been quite a surge in the number of doses given in the last 1 month. This is when we spoke in July. and we've gotten approximately 1.35 billion doses into people since then. So that's somewhat encouraging. In Asia and the world, we're still at a third have received at least one dose, 25% two doses. Singapore has surged ahead of these other countries. It hasn't reflected in our world in data yet, so I put the modifications in. And you can see in Asia, Singapore obviously is here, and in Malaysia, approximately 57% have received one jab, 41% two jabs, and Indonesia, 12% have received one jab. The data from Myanmar, it's not clear how accurate that information is. So there's been increased efforts to increase the percentage of people vaccinated in Singapore. I'm not going to go through these in detail. I've discussed these each month, and in May, June, and July, we had various measures. Been a lot of new measures in August. I'm not going to go through these other than the health promotions boards offering you $30 if you successfully get someone over 60 referred, which is nice. So there's more pandemic, there's more public health preparedness clinics available, and the previously infected are getting their one dose much sooner than they were before, but there's other measures taken as well. Notable things that are going to occur next month, maybe not in Singapore, but elsewhere, is that Pfizer is expected to apply for emergency use authorization for 5 to 11 years old. So be prepared for that discussion. So let's go through the lightning round. There's some fascinating topics to cover, and I'm going to try to do so in a logical way. Delta, as you know, has approximately 12 mutations compared to the wild type, and the nomenclature is a bit confusing. It's still known as Delta by WHO and GISAID, where it's now called a clade GK. It was formerly this clade. And Pango knows it, Pango lineage nomenclature knows it as B1 617.2. Delta Plus is being tossed around, but it's really not standardized nomenclature. The organism, the variant that has an additional mutation that makes it being called Delta Plus is still being called Delta by WHO, as it should. Pango has decided to give it its own title, AY.1, and there's AY plus up to 12 at least, and GISAID is still calling it GK. It has one additional mutation, which is also seen in beta, which allows beta in South Africa, from initially identified in South Africa, to have immune escape. That is really not seen quite so much in Delta Plus. It's not recognized as its own variant of concern. It is considered a sublineage of Delta and nothing more. It has not been proven clinically to differ from Delta despite this mutation thus far. And there's been this many cases across as of today. Delta has taken off. This is no surprise. This data doesn't show Delta to continue to rise based on some peculiarities of reporting, which I won't go into here, but we would expect it to continue to be the overwhelming dominant variant out there. How does Delta differ from the other variants of concern other than by mutation? Well, it replicates quicker. There's no doubt about that. It creates higher viral load person for person, and it does so quickly. It's more infectious. The number of patients on average infected from one patient is in the 5 and as high as 8 been reported, whereas the ancestral was in the 2 to 3 range. There are more infections that after people became vaccinated and after past infections. So it's more likely to reinfect you than alpha after you've been about a half a year after your initial infection. It faster replication and higher viral loads versus purely escaping from neutralizing antibodies, or is it waning immunity? It's not clear which of these creates or allows it to be more infectious and causing more infections after vaccination or past infections, but it may be a combination of these features that allow it to do so. The question is whether it's more virulent. It's a little tricky. There's a lot of data looking at this. There's certainly those who feel strongly that it is. There are those who feel strongly the data hasn't shown it to be so. So that's a point of contention. This is an old New York Times graph from early last year that's been modified with the Delta variant. The more you go to the right, it means the faster it spreads. You can see measles way out here and seasonal flu way back here. That means the R naught is even higher. The higher up on the graph, it means it's more deadly. So you can see bird flu, MERS, and Ebola quite high up, smallpox, et cetera. So Delta has found itself to be both more transmissible, it spreads faster, and possibly a bit more virulent. We said that that's still being debated at this time as data is being analyzed. So when you look at the variants in perspective, comparing them to wild type, this is alpha, beta, gamma, delta, obviously. Disease severity, alpha is definitely more severe. Delta may or may not be. Same thing with mortality, may or may not be. As far as evasion, alpha didn't do so. That's beta's claim to fame. It is able to evade neutralizing antibody. Not really that much with delta. There are those who will argue with this position, but it's not nearly as immune evasive or humoral antibody evasive as beta. As far as cellular immunity evasion, none of them have really been proven to do that. So there are variables which impact vaccine efficacy. I am not going to go through. This is a wonderful discussion in this article that you can see and look up. The video will be posted to YouTube, so you can go back and see this. But this is a great article with a wonderful discussion. And long and short of it is, impact on population efficacy is impacted by which vaccine is used, by the number of doses, and the timing between doses. We've made a pact to get people vaccinated quicker, so we've shortened the time between doses back to the standard schedule, whereas there is some data to suggest the longer the time between AstraZeneca doses or between Pfizer doses, the more robust the immune response and the broader the immune response. So that has an impact on the high antibody titers and the quality of antibody, and it may or may not have an impact on T cells. So Louisa showed this, and I'm not going to go through it other than just to say that Sinovac, you can see that there's varying data being reported for a variety, for Pfizer, Moderna, AstraZeneca, et cetera, et cetera. There's no Delta data for Sinovac that's been public release. There's been public press release saying it works, but there's really no data. The red line is right at 50%, which was WHO's line of it. That's the least amount of efficacy they'd like the vaccine to have. So more importantly is, what is the vaccine's impact on risk and death? The two, Dale and Louisa, have spoken of this and reinforced that there's no data yet that Delta has changed this relationship. And this is a great graph from Financial Times of all places, but beautiful graphics showing that if you're unvaccinated, your mortality is this, and if you become infected, and with vaccination, it drops. These possibly are a little bit low, but nevertheless, you get the idea. It's about a 10-fold log. But again, no data regarding about Delta stating that this relationship has changed. So let's talk about infection after vaccination, sometimes known as vaccine breakthrough. Well, there's certainly a decline in neutralizing antibodies at 8 months. And the focus has really been on neutralizing antibodies. That's what we've been measuring. When we see those go down, we're anxious that this person is at risk. And that's been fueling the booster discussion. But there's still high-level protection from hospitalization, severe disease, and death. We still may get breakthrough mild or asymptomatic infections, which have an impact on transmissibility, but we're not filling up our ICUs in our hospitals with patients. So there's got to be more to the discussion than just neutralizing antibody levels. That said, these are interesting findings. As far as Delta infected, the viral load, whether you're unvaccinated or vaccinated, same. Can you culture it from a vaccinated person? Can. That's troubling. Does that mean that vaccinated, unvaccinated are of equal risk to secondarily transmit the virus? That's a little disturbing. Well, no, they're not. Delta viral load declines faster in vaccinated, and Delta is less able to be cultured from vaccinated despite the same viral load. So this is a beautiful paper and an iconic table from our friends at NCID and Duke in US. And they show up, yes, early in the infection, vaccinated and unvaccinated have the same viral load, but with time, the vaccinated drop more quickly and drop below the level when we can generally culture vaccines. So that's a very encouraging, a shorter period of infectivity in all likelihood based on this. And this is a nice work recently published this last week, or a preprint put out from folks in the Netherlands, which showed with the same viral load, you're less likely to be able to culture it in the vaccinated compared to the unvaccinated. So again, what we're seeing is those who are vaccinated, then infected, have quicker decay of viral replication and they're less able to shed culturable virus. Therefore, secondary transmission risk is less in all likelihood, and duration of isolation required may be less. That's something for consideration. So to emphasize, despite infection after vaccination, so-called vaccine breakthrough, there's decreased morbidity and mortality. Louisa spoke to this just now. And this is just getting infected, whether you're symptomatic or not, there's a 5 to 8 times reduction with the vaccinated as opposed to the unvaccinated. There's a 25 to 29 time reduction in hospitalization incidence, and there's a 25-fold decrease in death incidence. So this is an impact on vaccine efficacy with time. And this is some data that came out this week or late last week from the UK showing that over time, vaccine efficacy for symptomatic, meaning mildly symptomatic, decays, and AstraZeneca goes a bit slower. But I think the important thing to look here is even though we're having increased cases in Israel, United Kingdom, and United States, and relatively highly vaccinated countries, the number of patients in hospital is not very high. Now, in the United States, there's only 50% of the population is vaccinated, but in the United Kingdom and Israel, it's over 60%. And when you look at the number of deaths per million, it's really not going up except in the United States, which is relatively unvaccinated. And more recently is reported going up in Israel, which is a point of potential concern. So this space needs to be watched. But let's talk about those cases in Israel. So 40% of the population approximately is not vaccinated, 60% is vaccinated. In the severe cases, not vaccinated, 214, fully vaccinated, 301. These are kind of close. Alamak, the efficacy is terrible. What's going on? So raw data can be misinterpreted. You've got to normalize this data. You've got to contextualize it. So you normalize the counts by adjusting for the vaccination status rates per 100,000. You need to look at that in each of these. Then you adjust for rate-related vaccination rates, or age-related vaccination rate. Then for severe disease risk disparity, because older are at higher risk for disease progression than younger, and older have been more highly vaccinated than younger. And when you do all that, you find this, you break them down by severe cases per 100,000, by severe case risk, which is higher in the older and lower in the younger. You then look at the number of severe cases, the breakdown of these cases, and you see, oh, okay, well, vaccine efficacy against severe disease and death is actually quite respectable and close to what it's always been since the vaccines have come out. So this is, one would say, reassuring. So this gets us to the point of boosters. Are they needed? Is it premature or is it genius? In theory, indications for boosters should be the primary vaccine series is not doing what it's supposed to, whether it's because of excess morbidity, mortality, or too much transmission, or it's waning because we've got established correlates of protection, whether that's neutralizing antibody, which I'm not sure is the whole answer, or a combination of various surrogate markers. Or there's a new variant, which is immune escaping, which I hope I've shown you that I'm not convinced the Delta is, at least immune escaping from neutralizing antibodies, or there's a proven booster available. So WHO has said that there should be a 2-month moratorium on boosters until everybody else gets vaccinated. And what are other countries doing? Well, just to look, everybody's anxious. Israel started off with immunocompromised hosts and then the elderly, and they've slowly worked their way down. And I assume at some point in time, it'll be everybody. The other countries you can see here, in the US, the FDA recently approved a third dose, not necessarily a booster, but a third dose as a part of a primary series for those who are profoundly immunocompromised, because their feeling is, and the data justifies it, 2 doses is insufficient. With 3 doses, they get an adequate response. But they're also recommending boosters for others, and more recently suggesting that everybody's going to get a booster. And you can see what other countries are doing, and there's others that I haven't mentioned. So if the goal is to decrease hospitalization, severe disease, and death, then give the boosters to those people that's been shown to be efficacious for, which is the immune compromised, solid organ transplants, and other comparably immunocompromised patients, and probably the elderly. But it's not supported for the rest of the vaccinated population yet. That data may come, but we haven't seen anything yet that says that the rest of the population is going to get it if we're trying to avoid hospitalization, severe disease, and death, because that's what is a burden on the healthcare system. If the goal is to prevent any infection, then give the vaccine to the unvaccinated first, not those who are already fully vaccinated, as the benefit gained from vaccinating the unvaccinated is a whole lot greater than the marginal benefit gained from giving a booster to the fully vaccinated. If the goal is to prevent transmission from healthcare workers, frontline workers, then prove that there's a booster that actually can do that. And I don't doubt that we will, but you have to do that to justify diverting a vaccine from others, if vaccine is finite. So this is a bonus round. This won't take very long, and I know we're late, but this is important information. We're going to talk a little bit about relevant to boosters about mixing of vaccine platforms, because the issue is, if you're going to get a booster, do you get it with the same vaccine that you received as your primary series, or do you get something different? So there's some data. I talked about this a month or 2 ago that came out of a study in UK, but it's been supplemented by data from Germany, looking at AstraZeneca. This is the Oxford vaccine. Then as the first and second dose, or first within the Pfizer dose second, the other way around, and then Pfizer. When you look at neutralizing antibody ratios, the AstraZeneca and Pfizer is pretty darn high, almost as high as the Pfizer. When you look at T-cell response, cellular immunity, the AstraZeneca than the Pfizer is much better than the Pfizer and you don't get it when you go vice versa. When Pfizer's first and AstraZeneca second, you don't get that boost. So this looks sweet. The Germans independently did their own study, AstraZeneca, then AstraZeneca, then Pfizer, and Pfizer, went a little farther apart, 10 weeks apart. The best neutralizing antibody was the, again, AstraZeneca, Pfizer, and the best T-cell response, AstraZeneca, Pfizer. You can see here neutralizing antibody when you did the AstraZeneca, as opposed to AstraZeneca, the Pfizer, you got a higher level with the Pfizer, with that combination, the AstraZeneca than Pfizer. When you look here, just using AstraZeneca twice, there's a first and second dose, you get neutralizing antibody that against wild type reasonably high, less so for the variants. But when you used AstraZeneca, then Pfizer BioNTech, you got sweet level of neutralizing antibody to all the variants. So AstraZeneca adenovirus vector vaccine followed by Pfizer mRNA vaccine gives high neutralizing antibodies, increased cross-variant neutralizing antibody, and robust cellular immune response. I suspect any adenovirus vector vaccine will do this, and the same with mRNA vaccine, but that's yet to be proven. So vaccine sequencing to produce high neutralizing antibodies and T-cell responses, which we think is what we want to decrease both breakthrough infections or infections after vaccination, and to maintain and prevent severe disease. It looks like, and I didn't present the data here, that natural infection, then an mRNA vaccine is the best. Gives you great T-cell response and gives you great neutralizing antibody. Next is what I just spoke about, the AstraZeneca vaccine or an adenovirus vector vaccine, followed by an mRNA vaccine like Pfizer. That's pretty darn good. Not quite as good as number one, but it's pretty darn good. mRNA then mRNA, so Pfizer then Pfizer, not as good, but pretty good, and what we've all received. mRNA then adenovirus, less good. And then adenovirus, the least good. Now, these are just a few permutations, and whether this holds, this is for primary series, whether this holds for boosting or not is yet to be seen. So that it has to be proven, but it is an interesting concept. Where protein subunit vaccines like Sanofi or Novavax or inactivated whole virus vaccines, such as Coronavac and Sinopharm or Sinovac will fit in is yet to be seen. So in summary, and thank you for staying with me, those of you who have, Delta confirms, our experience with Delta confirms that vaccinated are safer than unvaccinated without a doubt, but not 100% safe. Calls for booster for everyone are premature, but no doubt that they're needed for those who are immunocompromised and probably the elderly. Mixing vaccine platforms seems to be quite immunologically encouraging, and whether this manifests itself as improved clinical process is yet to be seen, but it's highly suspected that it will. And with vaccination, we've evolved into a pandemic of the unvaccinated as opposed to a pandemic for all. The question is, will we revert? And only time will tell, and you'll have to tune in next month to find out. So with that, I'll quit sharing and thank everybody for staying with us. And Dale, ask you to introduce, tell us about your video.
Thanks, David, and congratulations on that presentation. You packed a lot of stuff in there. I'm going to watch YouTube afterwards to catch up on that. So listen, I showed a slide before how hard a time Vietnam was happening. They've had a lot of TikTok challenges in Vietnam. I want to show some cuts of one. This is not the first one, but I do think it's the best one. It's the song is by a performer called ICM. He's a very successful local guy, and it's a very catchy tune. I expect Louisa and David, both of you, to get grooving.
Jump along. All right. Well,
get
thanks
grooving, as we said in the 70s.
Thanks, Dale. It leaves me to thank our guest, Thierno, and Louisa and Dale for spending their Thursday evening with us. Next month's episode will be on the 23rd at 7 p.m. Join us then. Do submit your questions either through the chat box, which will be open for 10 minutes at the end of the show. And we're happy to take questions and suggestions. We need lots of things to think about. And our pandemic song of the month is called Memories. It was released by Maroon 5 in 2019, with this version being sung by One Voice Children's Choir and contributed by none other than Dr. Louisa's son. Thank you very much. It's a particularly sweet version sung by this choir, reminding us, while there may be chaos, fear, uncertainty, there are things that still bind us as one, which is memories of those we've loved and lost. So until next month, stay safe, wear your mask, wash your hands, socially distance, stay informed, and encourage everyone you know to be vaccinated. Thank you for watching, and good night.
Here's to the ones that we got. Cheers to the wish you were here, but you're not, 'cause the dreams bring back all the memories of everything we've been through. Close to the ones here today, close to the ones that we lost on the way, 'cause the dreams bring back all the memories, and the memories bring back you. There's a time that I remember when I did not know no pain, when I believed in forever and everything would stay the same. Now my heart feel like December when somebody say your name, 'cause I can't reach out to call you, but I know I will one day. Yeah. Here's to the ones that we got. Cheers to the wish you were here, but you're not, 'cause the dreams bring back all the memories of everything we've been through. Close to the ones here today, close to the ones that we lost on the way, 'cause the dreams bring back all the memories, and the memories bring back you.
Trái đất tôi yêu màu xanh, xoay vòng quanh mặt trời, cô viết xe đi thật nhanh. Trong tình yêu, tinh thần luôn rạng ngời, áo trắng xin mạnh mẽ lên, kiêng căng thêm qua hàng đêm, vì mọi người vẫn luôn trao niềm tin lên đôi vai suốt bao ngày. Nào mình cùng đón ban mai dịu em, xoa bàn tay, xoa sạch đi vì quần hạnh phúc khi đeo khẩu trang. Quên buồn đau, không được nghĩ tiêu cực vì chúng ta là Việt Nam, không ngại chi